Welcome back to OMFS Essentials. Today we are discussing a critical component of wound management, the surgical drain. A drain is any material that acts as a channel for the escape of fluid, such as blood, pus, or exudates, from a tissue dead space or body cavity. The decision to place a drain, what type to use, and when to remove it is fundamental to preventing infection and ensuring uncomplicated healing. So, let's break down the key principles. 1. The purpose of a surgical drain. Drains serve two primary functions: prophylactic and therapeutic. Prophylactic, or to prevent. After a major surgery, like a tumor removal, a dead space is often left. This space can fill with blood, lymph, and exudates. A prophylactic drain removes this fluid as it accumulates. Why? This removal is essential. It obliterates the dead space, allowing the raw tissue surfaces to collapse, come into contact, and heal together. It also removes a potential nidus for infection. Now, therapeutic, or to treat. This is used when a fluid collection, such as an abscess or hematoma, has already formed. The drain is placed to promote the escape of the collected fluid. 2. Principles of drain placement and management. How and where a drain is placed is just as important as the drain itself. The cardinal rule: a drain should never be brought out through the primary operative incision. It must always be brought out through a separate stab wound. The rationale: a drain acts as a two-way conduit. Bringing it through the main wound invites bacteria into the surgical site, guarantees an infected wound, and prevents the primary closure from healing properly. Gravity versus suction. Passive drains, or by gravity, drains like corrugated sheets must be placed in a gravity-dependent position to be effective. Active drains, or by suction, vacuum drains are highly effective and can be placed in a non-dependent site, i.e., uphill, because the negative pressure actively pulls the fluid out. Material and fixation. The drain should be soft, smooth, non-irritant, and preferably radio-opaque. It must be secured to the skin with a stitch to prevent it from coming out, or worse, disappearing into the drainage cavity. Key precautions. Do not place drains near vascular suture lines, anastomoses, or across joints where fibrosis could impair function. 3. Types of surgical drains. Drains are broadly classified by their mechanism. A. Passive drains, by capillary action or gravity. Gauze drains or wicks. The mechanism: these act by capillary action. This is a critical point. Gauze is excellent for packing a cavity to achieve hemostasis, but it is a poor drain. Once it becomes saturated with fluid, it swells and acts as a plug, obstructing further drainage. It also acts as a moist channel for bacteria to travel into the wound. Corrugated rubber or Portex drain, sheet drain. The mechanism: this is a true passive drain. Fluid drains by gravity along the grooves and corrugations. Note: the older red rubber drains are irritants, which helps form a fibrous tract. Modern Portex drains are less irritant and have a radio-opaque line, making them easier to identify on an X-ray if lost. Penrose drain. Description: a simple, hollow tube of thin latex rubber. When gauze is placed inside it, it's known as a cigarette drain. B. Tube drains, cathars. Description: these are simple tubes like a red rubber or Malacut catheter used to drain high volumes of fluid. Advantage: they can be connected to a collection bag, creating a closed drainage system that reduces infection risk. Disadvantage: the inner hole can become blocked by debris. C. Active or suction drains, vacuum drains. These are the most common modern drains, such as the ReadyVac or RomoVac drain. They consist of a perforated tube connected to a collapsible bulb or bulb that provides continuous negative pressure. Advantages: 1. Closed system. This is the key benefit. It significantly decreases the incidence of infection. 2. Location. It can be placed at a non-dependent site. 3. Efficiency. It is highly effective under large skin flaps, such as after a radical neck dissection or mastectomy. Disadvantage. The continuous negative pressure may sometimes induce bleeding. 4. Drain removal. The timing of removal is crucial. Prophylactic drains, these are typically removed as soon as drainage subsides, often after 48 hours. Therapeutic drains, these are left in place until the drainage has ceased. The technique. 1. Check for blockage. If drainage suddenly stops, the drain may be blocked. Displace it, pull it back 3 to 4 centimeters to see if any fluid is released from a pocket. 2. Gradual removal. Once drainage is minimal, the drain should be removed gradually. Withdraw a few centimeters each day and refix it. The rationale. This allows the drainage tract to heal from the depth upwards, which is essential to prevent a pocket of fluid, a sinus, from forming. Summary. Surgical drains are a double-edged sword. They are essential for obliterating dead space and preventing fluid collection, but they also act as a potential portal of entry for infection. Key principles. Always use a separate stab incision. Place passive drains in a gravity-dependent position, and use a closed or vacuum system whenever possible. Types. Understand the difference between passive drains, corrugated sheets, problematic drains, gauze, and active drains, vacuum drains. Removal. Remove drains gradually to allow the tract to heal from the bottom up. Proper drain management is a cornerstone of surgical care, preventing complications like hematomas and abscesses and setting the stage for uneventful healing. You've been listening to OMFS Essentials. As always, keep mastering the essentials.